do better, motivates me to do better with this talk. But please understand, I'm not the keynote speaker, and he said the job of the keynote speaker is entertainment. I am not the keynote speaker. Okay. My name is Lori Greenwood, and I'm on faculty here at Texas A&M University. Mike Greenwood being my husband, and so he asked me to speak with you today. I'm an athletic trainer. So for some of you, I might be the person that might be telling you that, slow down, you're hurting my athletes. For others of you, I might be the one that's hopefully working in tandem with you in order to be able to make your athletes and to make your individuals trying to become more fit to excel in what they're trying to do. So what I'm going to be speaking to you about today is myofascial release. Now, I'm on faculty here now, but for many, many years, I was a clinician. I worked primarily at the college and university level with a variety of different sports, and I worked hand in hand with strength and conditioning specialists. So in order for me to do my best job, I need to understand what's going to be happening during their preconditioning, during their fitness routines, during their exercise routines, when they get injured and we conduct rehabilitation programs for them, and then jointly we discuss functional exercise and functional return. Then I'm working with strength and conditioning specialists in order to do that. And one of the things that you may already be employing within your programs is myofascial release. So my objective today is really to discuss what myofascial release is, how it might be employed within your program, what the science is, if any, behind it. And then I'm also hoping to gain some information and knowledge from you. So at the end, certainly you can ask me any questions that you would like, but I'm also going to turn it over to you and ask how you're utilizing this in your program and what hints and tips and suggestions that you have for all of us that may be beneficial to all of our exercise programming and all of our conditioning programs, as well as to therapeutic exercise rehabilitation for clinicians who might be working with injured athletes as well. So myofascial release, basically if you just look at the name, it's going to tell you what it is. Myo being muscle, fascia, as you know, we'll discuss that a little bit further, and release. Release is going to have to tell you that there's something that is restricted, something that needs to be released. One of the things that most commonly is utilized, I would assume in your settings, is you're not going to have a lot of time as an individual clinician to do individual manual therapies on your patients or your athletes or the individuals that you work with. So when they come into our rehabilitation facility as an athletic trainer, I'm more likely working one-on-one with them. So I'm more likely to be able to employ clinician myofascial release. However, when you're working with large groups of individuals, especially individuals that may not be injured, and you're wanting to employ this within your conditioning programs, you're not going to be able to do it on a one-to-one basis. So that means it's going to have to be something that is self-administered. And so I'll spend the most time today talking about self-administered. One of the reasons for that, as well as we actually do have more research that has looked into self-administered than we have research that's looked into clinician-administered. So most of you probably think of myofascial release in terms of self-administered as foam rolling. Absolutely it is a foam roller. I think everybody should own one. Everybody should understand the different types. It doesn't cost very much money, and it can be used for tons of different things. So hopefully you all have foam rollers in your facilities. We have them at home. My son is rehabbing from a back injury, so he uses his pretty frequently and constantly. I'm not as young as I used to be, so I use it very frequently and constantly myself. Clinician employed, we'll talk about that really briefly to begin with. One of the things that if you are a clinician, you will be working with myofascial release as an evaluation tool initially. So rather than a patient or an athlete telling me that they feel tight or they feel restricted or they feel sore or they feel like they're impeded or have dysfunction in some way, I am able to actually feel that. So with manual therapy, with hands-on technique, I will go through an evaluation process where I feel to see if there's any restrictions. If you're working as self-administered, then it's more likely that they're not necessarily going to get the evaluation part of it where you're feeling restrictions. They'll tell you. or depending upon what they're speaking about in terms of their dysfunction or their muscle imbalances, you may be thinking, I bet they have some problems here, I bet they have some restrictions here. Certainly you can employ it from an evaluation point of view and then still allow them to use a self-administered foam roller, tennis ball, or amazing tools that are out there that can be used for this purpose. The history of the term myofascial release really came off of trigger point therapy. And trigger point therapy really was most highly discussed in Travell's myofascial trigger points. Certainly if you're a clinician, athletic trainer, physical therapist, or what have you, you have your trigger point charts up in your facilities and you have your trigger point manuals that you utilize. And this is really where myofascial release came from, is another way to utilize the tools and techniques that we have in order to initially treat trigger points. Now, this is where it can get a little challenging, especially if you're trying to look into the literature and you're trying to compare and contrast the literature. Evidence-based practice, determine whether or not this is something that is really usable within your facilities. It's called a lot of different things. So I'm going to use the generic term myofascial release, but it might be called myofascial stretching, strain counterstrain, Rolfing, which is a deeper technique, just basic generic soft tissue mobilization or manual therapy. Active release therapy, that's kind of one of the newer ones, and you can receive a certification in it. And then Graston technique is obviously in the last few years become very big, very popular. We really don't have much in the way of science behind it in terms of outcomes, but it is something that is utilized quite often, especially in a therapeutic setting. But Graston has to be done one-on-one. So as a clinician, that is going to take my time where I can only work on one patient when I'm using Graston. If you're using something that's self-administered, then a variety of different athletes or patients at the same time could be using this, and they can use it as a home exercise program as well. They're not going to go home with a Graston tool and perform Graston on themselves, but with a handy old foam roller or a tennis ball or some other tools that you might want to use, they can use this in clinic, they can use it in the gymnasium, they can use it when they go home, and it's not very expensive. So let's talk about fascia since we're talking about myofascial release. Well, fascia is a lot more complicated than I'm going to make it out to be today, but you understand fascia if you eat meat at all. So whether or not you eat red meat beef or whether or not you eat chicken, if you cut into it all, if you try to pull it away from the bone, you have seen fascia. And there's two primary layers that we deal with fascia. One is the superficial layer. That is the layer that is going to really override and encompass all the muscle and organ tissue. So it's a nice fine sheen that really is going to be on top of all your meat. I know that sounds awful, but you know what I'm talking about, right? All right. If you try to get a little denser than that, if you try to get a little deeper than that, this looks pleasant, doesn't it? Okay, I don't know what you're having for lunch today, but this looks pleasant. Now what you're looking at is we're going to get into the deeper layers. So deeper fascia is going to be in between the muscle fibers. It's going to be attaching to the periosteum of the bones. It is also going to be something where it's going to be much more difficult to directly manipulate because it's much deeper. Depending upon how much skin, adipose tissue, how large the muscle is, cross-sectional area of the muscle, your deeper fascia might be actually quite deep. That's going to be part of the discussion today, is are we really able to address deeper fascia with myofascial release techniques? Okay? Now, this is connective tissue, so this is soft connective tissue. All soft connective tissue are going to have primarily the same properties. Collagen is going to be the main substance that is going to be comprised of. Collagen is basically what's going to give connective tissue its strength. Elastin is what is going to give connective tissue its flexibility, its ability to stretch or transform or change shape and return to normal or baseline positioning. So what you're going to see with your connective tissue is it is very hard to mold and manipulate because collagen is viscoelastic. And viscoelastic tissue doesn't really like to change shape. It doesn't really like to be deformed. It doesn't really like to be stretched. Can you do it? Yes, you can potentially. However, what we deal with also is the amount of elastin in connective tissue. And what that means is it has a tendency to kind of bounce back. if you've ever employed any flexibility routine at all, any sort of stretch routine at all, you realize that the effects of it are very short term. So if you want somebody to increase their hamstring flexibility and you have them do a standard hurdle hamstring stretch, how long is that increased flexibility, if you do get any, going to last? It's not very long. It's actually quite temporary. And that's a whole other discussion about the success of stretching and flexibility in general. So what we're looking at is something that contains a high water content, hyaluronic acid, glycoproteins. So it has a lot of chemical and protein components to it. But one of the big things to keep remembering, water. So that's one of the things we'll have to come back to again. When we talk about myofascial release, when we talk about restrictions of fascia, we also are going to have to bring up nutrition and fluids. All right, so fascial restrictions. Well, as I discussed, fascia is going to be basically a sheath that's going to encompass your entire body. So if you want to think of it, if I put a compression shirt on and compression tights on, then I'm going to have basically that fascia, especially if you're talking about superficial fascia, that's going to cover the entire myo or muscle tissue. We're not really interested right now in the fascia that is going to cover organs or viscera. We're interested in the muscle or the myofascia. It can't be separated. Now, that's not true. It can be separated, but it can't be separated without damage or without harm. If you want to have a chicken breast and you want to pull off the skin of the chicken breast, or you want to pull the breast away from the bone, can you do it? Yes. If the chicken were alive when you tried it, it probably wouldn't be a very good thing to have happen there. So is it possible? Yes. Could you do it without harm? No. So what we're trying to do is make changes and adaptations to tissue without causing harm. So the other thing that's important to realize is because this is somewhat a kind of continuous sheath throughout the entire body, is that if you have restrictions or tightness or dysfunction in one area of the body, it can affect other areas of the body as well. As the clinician, this can be incredibly frustrating for me to try to determine what is the origin of the problem. What I may actually be treating, or what may actually be an area that my athlete is describing as painful or dysfunctional, that may not actually be the origin of the problem. So it's, sometimes it's a big murder mystery trying to figure out exactly what is the source of the problem, what is the source, in this case, of the restriction. One of the ways you can think about it is the sock analogy. If you have a nice new sock that you buy, it has maybe a really good weave to it, maybe more of an expensive sock, and you put it on, it fits really nicely, you wear it for a while, you take it off, it really maintains its shape very nicely. You wash it, it's ready, you put it back on the next day, and it works very nicely for you. What if there was a tear in it? But you really like this sock, so you decided you're going to keep it and you're going to stitch it, okay? So now we have an injury, and we basically have scar tissue. Or maybe you decide that I'm not going to stitch it, I'm going to use some sort of Dermabond material. So I'm going to put some sort of glue on my sock, all right? Now when you put it on the next time, that glue or that stitching is a restriction. And it's going to affect the way it fits. It's going to affect the way it feels. It's going to affect the entire sock and the integrity of the entire sock. So that's kind of what we're talking about here. So an example would be your ITB is an area that is oftenly utilized for foam rolling or myofascial release techniques. It's a very common area to suffer restrictions from. It's also a problem when we look at muscle imbalances. And so one of the things that you're looking at is, all right, well, let's see where the restriction could be here. Well, if you're looking at the aponeurotic tissue here, very thick, fibrous, dense tissue, well, your fascia is actually feeding into it from the gluteal muscles, from the tensor fascia lata, from a little bit higher actually, what this is not showing in the lumbopelvic area as well. So we could be having this kind of ITB friction syndrome problem on the lateral side of the knee. That's not where our problem is. The problem actually could be much higher up. Now, could it be other things? Leg length discrepancy, muscle imbalances, biomechanical flaws? Absolutely. But is it also possible that either chicken or the egg, we also have some fascial restrictions that perhaps, maybe in a pretty straightforward fashion, we could address? So what happens with fascial abnormalities? How does fascia become abnormal? Well, through trauma. That can be macro trauma or micro trauma. That can be acute trauma. Or what we tend to see more often is microtraumatic or chronic injuries over time. So it's not something that your athlete comes walking in and says, oh my gosh, I've hurt my fascia. Okay? I've never heard an athlete say that. I don't know if you have. But what they'll talk about is this feeling of tightness or this soreness or this dysfunction, or it's just not right and I can't do what it is that I need to do. So we're also looking at the fact there's other things that go into healthy fascia and healthy myofascial tissue. High water content. Hydration matters. Collagen, connective tissue, high protein content. Nutrition matters. Also, poor posture. We'll have a posture speaker that will be coming up as well. And so a lot of the things that we have to think about in terms of doing all the correct things correct is going to impact myofascial tissue as well. All right, fascial adhesions. This is one of the primary theory regarding fascial restrictions. How does fascia become restricted? Well, we already said possibly secondary to injury. When connective tissue heals, primarily it's going to heal via scar tissue. That's just the way it goes. Well, scar tissue tends to lay itself down in an unorganized fashion, unless you tell it how it should lay itself down. During the phase where you are basically getting proliferation and remodeling, the collagen fibers, fibrous tissue is coming in. Won't spend a lot of time talking about that. But basically, it needs a signal. It needs a stimulus. Where am I supposed to go? How am I supposed to line up? Well, in general, collagen for most connective tissue is going to have a high percentage of parallel fibers. Not totally parallel fibers, or that's not going to give its crossed weave strength that a lot of tissue needs, but primarily it's going to be parallel in nature. Let's say that to make it real simple and make my picture work really nicely too, okay? So I also think of collagen fibers like pasta, okay? No, I don't make my own pasta. I get it out of the bag, I throw it in the boiling water. And then when I overboil it, I'm a great cook. When I overboil it, it's going to look like this, okay? Disorganized scar tissue. So imagine that you have, let's say, a hamstring injury, a moderate to severe hamstring injury. It's going to heal via scar tissue, and there is no stimulus to tell the collagen how to lay itself down. So you're going to get this kind of mishmash here. That doesn't look very functional to me. And it's not very functional. But in a smaller sense, this is happening all the time. You have to push your athletes very hard. As Lance said, there's going to be pain. There's going to be soreness. However, what we need to look at is how can we offset that? Knowing somewhat that has to occur, and knowing in this case, with my discussion, fascia is somewhat going to take the hit. There's going to be this constant process of healing and remodeling. It might be in a very microscopic area of your fascia or of other types of tissue, but it's going on chronically. It's going on daily, daily, daily. So are there little things that we can do that don't take a lot of our time, aren't expensive, that could potentially offset that and allow our athletes to go further and faster without dysfunction and disability? So fascia can become fibrotic. If there's not spacing in between my pasta there, my pasta's going to stick together, okay? What goes in the spaces? Well, let's make it really simple and say there is ground substance in the spaces that's highly fluid content. Has a lot of water in it, has other particles in it as well. What I need is them to glide and slide across each other in order to get my sock and the fibers of my sock to stretch and then to retain its position. Injured connective tissue is going to heal via scar tissue unless it's very minor. Muscle sometimes can heal without scar tissue, but it has to be a very small imperfection of the muscle, a very mild injury. So most of the time, you know what, you're going to get scar tissue. It's not a bad word, that's just the way it is. But what we need to know is how can we help that scar tissue remodel itself? How can we help that scar tissue lay down the lines along the stress? Also, we need to know the difference between normal, healthy connective tissue and scar tissue. Scar tissue is not the same tissue. So when you tell an athlete you'll be as good as new after an injury, no, they won't. No, they won't. Because they're going to heal through scar tissue, and they didn't have that scar tissue before. Scar tissue is not as strong. It's not as flexible or elastic. It doesn't have the same level of vascularity or innervation. It is not the same tissue. So therefore, what we have to do is try to minimize the deleterious effects of scar tissue. And we also have to be able to understand that this is kind of constantly forming in our athletes, especially those that are performing to their highest and we're really pushing them. So we have to find a way to try to offset this. This is one of the things, I worked gymnastics for many, many years. And they are fairly limber young ladies. I call them my Gumby athletes. Okay? So when I think of range of motion, their range of motion is beyond within normal limits. Okay? And they will constantly, as a lot of athletes do, track athletes are very known for this as well, they're very attuned to their bodies. And they will tell you, it feels tight, it feels restricted, it just doesn't feel right. Your baseball pitcher may tell you, I'm losing velocity, I can't get my arm back far enough. You measure them and it's fine. But they're telling you, no, it doesn't feel right. Your track sprinter will tell you, the hamstrings are feeling tight. I measure them within normal limits range of motion, within normal limits flexibility, sit and reach, all the kind of things you want to do. It's normal, you're fine. No, they're not. They know, they feel it. So what accounts for that sensation when they do have normal, quote, flexibility, they have normal range of motion? Maybe it's fascial tightness, maybe it's fascial restrictions. And so it's not going to help you just have them do more stretches. You need to do something to try to release the restriction. Compensation is also one of the things that we have to be concerned about when you have restrictions in the fascia. When you have an area of tightness or restricted tissue in one area of the body, because of the kinetic chain, you're going to have to make up for the slack in some other area of your body. This is an amazing thing about athletes. They are going to get the job done. They may not have the strength, they may not have the flexibility to do it without injury though. Or they may compensate. So they're going to find the strength, they're going to find the flexibility, they're going to find the range of motion somewhere else in their kinetic chain. But you know what? That other tissue wasn't made to take the stresses of what they're trying to require of it. So they're going to get breakdown and they're going to get injury. We also have to look at compensation in terms of muscle balances. Usually you'll have weakness on one side, you'll have tightness restriction on the other side. So we need to understand that, and we can evaluate that. We're able to assess that, and in some cases what might happen is, as I said before, all your measurements are normal, but they're still dysfunctional. There's still something wrong with it. It might be something that's not as directly measurable. It might be something, however, if you're trained to do this, that is palpable. You can feel fascial restrictions. And your athletes are telling you that it doesn't feel right. So what I'm going to do is talk about the most common claims that are made in the literature. And when I say in the literature, I'm not necessarily saying in the research literature. I'm talking about maybe where your athletes are going to go to get their information, right? That's one of the things we have to concern ourselves with. There's tons of information out there. You're getting it, our athletes are getting it. Is it good information? Has it been reviewed? Has it gone through a research process? Is it evidence-based? Well, here's the most common claims. So the first one goes back to the sticky tissue theory. It goes back to overcooked pasta. It goes back to things sticking together and not being able to slide and glide across each other as it should. So that's really kind of the sticky pasta theory. With that, what's going to happen is you have adherence, you have restrictions, and that means you're going to have a deleterious effect of that on down the kinetic chain. Dysfunction, imbalances, and perhaps reduced performance and or injury. So what's the evidence in order to suggest that there actually is the sticky pasta theory, and therefore myofascial release is one of the things that we can use in order to treat it? Well, the news isn't really great, especially if you talk about deep fascia. Fascia is incredibly strong. Collagen is actually a very strong type of fiber. So when you talk about fascia in terms of its cross-sectional area, its breadth, its depth, it's quite unlikely that you're going to be able to make a permanent change to the fascia through external means that don't cause further injury. It's kind of to say, okay, we all understand the stress-strain curve. We understand that from a position of maybe range of motion, flexibility, stretching types of exercise. If I employ a stress that is only within the elastic range of connective tissue, once the stress is reduced or diminished, what's the position of that connective tissue going to be? It's going to spring right back, isn't it? That's one of the wonderful elastin properties of viscoelastic connective tissue. But if I just work in that elastic range, I'm not making a difference. I'm not making a change. All right? In order to make a permanent change, I need to go into what's called plastic deformation. For plastic deformation to occur, though, there's likely to be some damage, some micro trauma. Okay, we might be able to live with that. We might be able to control that. But in order to really make large magnitude changes in something that has such a high tensile strength, you would have to do damage. So it is quite unlikely, actually, that just taking a foam roller and sitting on it and pressing on it and squishing the fascia is really going to make a change in terms of permanent deformation that doesn't cause damage. Now, I haven't said yet you shouldn't use it or it doesn't work. I've just said the evidence says that's probably not the mechanism through which it does work. However, we have seen changes in range of motion short term, just like some stretching exercises, using myofascial release. So there have been a couple of studies that actually have looked at increases in range of motion using myofascial release, generally using self-myofascial release with foam rollers, and whether or not there was a change in range of motion. They have shown a change in range of motion, acutely. They have not shown a long-term change in range of motion. We're used to that, aren't we? It's really hard to make a long-term change in flexibility and range of motion. So this is kind of normal for us. This is an interesting study where they actually compared warm-up techniques, passive warm-up. So they used a 20-minute hot pack, which is a passive warm-up technique, wanting to see whether or not that technique would increase range of motion, and they compared that with 3 minutes of a myofascial release bout. And what they found was there was no difference between the enhanced range of motion between a 20-minute hot pack and a 3-minute myofascial release. Okay. So what does that tell me in terms of myofascial release use and the practical sense of using it? Well, it tells me that there are some short-term range of motion benefits from using myofascial release. It does not tell me that there's long-term benefits. But is it possible that even a short-term benefit would allow you to have them do an exercise or have them go through an exercise routine that they may not otherwise be able to do because they lack that range of motion or flexibility to do it? It's not going to stay around. When we come back tomorrow, we're going to have to do the same thing again. But I still was able to maybe push them a little bit further in their exercise or their conditioning programs because I made this short-term change, possibly. If you have to do passive warm-up techniques, maybe you're going to save some time. Now, why would myofascial release actually increase range of motion if it's not through the sticky pasta theory? Well, part of it, if you think about it, whether it's manual myofascial release, whether I'm massaging, whether I'm using a foam roller or a tennis ball, there's friction there, isn't it? Friction is going to provide heat to the tissue. Providing heat to the tissue, it's connective tissue, it's collagen-based. Collagen really likes heat. It's viscoelastic. Viscoelastic really likes heat. So I am giving it heat in a way, it's just being kind of self-produced. Trigger points. Well, this is kind of where it all started. So we kind of have to think about, well, what actually are trigger points? I don't know. I don't know. I'm not going to stand up here and say I know it or even know they exist. But I do know if I reach back here right now, I have a really sensitive nodule. That if I push on it really hard for about 30 seconds, it's going to hurt like heck while I'm pushing on it. But when I'm done, kind of feels better for a little while. And then it gets tight again, and then I got to push on it again, okay? So what are they really? Well, hypersensitive areas. Okay, what causes these hypersensitive areas? Well, I can give you tons of different theories. I can't prove any of them. Is it we actually have localized area of muscle spasm? Possibly. Is that we have local ischemic area within the muscle and or fascia tissue? Possibly. Is it there's actually micro damage to the tissue? Possibly. Is it there's not enough ATP in the area in order to make the muscle relax after it's already contracted and spasmed? Possibly. I don't know. But I do know that there's actually quite a few techniques that can successfully reduce pain, reduce point tenderness, and increase function in areas where I can feel something. I can feel a nodule. And there hasn't been an injury where I'd say, ooh, we got a big wad of scar tissue there. I mean, you don't generally feel that, by the way. But I can feel there's something not right there, and it's point tender, right? And my athlete's telling me I'm having problems in this area. So yeah, I think trigger points exist. Do I actually know the cause of them? Not necessarily. But I do know that I can use a lot of manual forms of therapy to treat them. I know I can use electrical stim to treat them. I can use noxious stimuli to treat them. I can use myofascial release to treat them. Okay? So cause is really unknown. You may have a theory that you basically believe in or that makes sense to you, and then you may have an intervention approach based on that theory or mechanistic theory that works for you. Great. If it works, do it as long as it doesn't cause damage. Well, we do have quite a few studies that have looked at trigger point therapy using myofascial release. And they do show decreased pain, decreased point tenderness, decreased function, dysfunction secondary to the pain. So yeah, it works. Use myofascial release for trigger point therapy. That's fine. But how does it work? I still would like to really, really understand how this works. Well, I don't think it's just one or the other, by the way. I think all of these are contributing factors to why it works. First of all, is this a general relaxation theory? Just about any form of manual therapy, you might think of it massage therapy, as long as it's not done too vigorously, there's going to be a general relaxation of the body. If you've ever had a massage or you've ever had a manual therapy technique that's not vigorous, it was supposed to be a relaxation massage or a wellness massage, you kind of have a general relaxation about you about it, don't you? And they don't necessarily have to play the music or having the trickling water, right? It's just if that is the reason that's employed, most of your studies are going to tell you absolutely general relaxation. Well, if I get general relaxation, does that not also mean I might get some focused relaxation along with that? That could overall reduce my pain and discomfort. Okay. Increased sense of well-being. The psychological aspect of manual therapies, the psychological aspect of massage therapy has been shown time and time again, absolutely there's psychological benefits. You have an increased sense of well-being. If you have an increased sense of well-being, generally that's going to say that either I have reduced pain or I feel better about my pain. And that matters. All of that can reduce pain and reduce dysfunction secondary to the pain. Pain habituation. We get used to being in pain. If we employ more pain and more discomfort, we get used to that and we can bear more pain. This is what you do in your conditioning programs all the time, is it not? You push them higher, you push them faster, you push them more intensely. Hopefully you do it in a progressive fashion that's safe. But that's what you're doing. And then they get used to being pushed harder. They get used to working harder and then go to the next level. Well, think about this. Let's say I'm using myofascial release and I'm using a tennis ball. And I'm sitting on the tennis ball and I'm rolling around underneath my piriformis. Well, that sounds like fun. Okay? Sciatic nerve's right there too, by the way, so you do have to be careful. Okay? That's not incredibly comfortable. Okay? Now let me take a hockey ball or a hockey puck, or let me take a lacrosse ball. It's much harder. Or let me take a tennis ball that now has the kind of ridges on it, right? We have myofascial release balls, okay? And now I'm going to roll that around. That sounds even more fun, okay? But you know what? now once I've done that and I go back to the tennis ball, that tennis ball's feeling pretty good, okay? That's pain habituation. So is it possible that myofascial release actually works just because you're causing them more pain and so the pain they had to begin with is not that bad to begin with? Possibly. I mean, that's my overall success in my career, okay? And then we have the descending pain modulation theory. It's a very similar type of thing. Basically what we're doing is we're using a well-known pain management technique based on descending pain pathway. So let's say you stub your toe or you crack your shin on the coffee table, okay? Your brain tells you, I've got pain, okay? So that means a pain signal had to make it up to the brain, okay? Then the brain's going to decide what to do about it. Now, there's a reflex, hopefully, that's going to happen there, where you move your toe out of the way or move your shin out of the way or what have you. But in order for you to feel pain, the brain has to have interpreted it as pain. Then it's going to send a signal back down again that basically says, okay, what are we going to do about it? What are we going to do about it? Is the muscle going to spasm and I'm going to get muscle guarding? Is injury now occurring? Now I'm in my acute inflammatory phase of injury, what have you, okay? The clear point of this that's so important, and a lot of you understand gate control theory of pain, right? Is right here at the gate. If I can stop it at the spinal cord level and not let my brain in on it, then my brain doesn't know that I did something that caused me pain, okay? Is anything going to be 100% effective? Maybe narcotics. We're not doing that, okay? So what I have to look at is saying, okay, how can I shut the gate? Well, I'm not shutting the gate ascending because my brain already figured it out. But maybe as it loops back around before it goes back up again, I can shut it down. How do I shut it down? I've got to give my brain something else to work on. So I have to give my brain some other type of sensory signaling, some other stimuli. So if you stub your toe, you crack your head, first thing you're generally going to do is you're going to grab it. Maybe you're going to squeeze it. Maybe you're going to rub it. And so what I'm doing is I'm sending non-painful stimuli up to my brain through the gate. It's going to get there faster because it just so happens that pain fibers actually run pretty slowly. These other fibers run pretty quickly. And so I'm able to get that sensation to the gate. Gate closes, very simplistic. And so now I don't have as much pain information that my brain is able to discern. Okay, is that possible? Sure, it's possible. Especially if it's something that has a high intensity of sensory input. If I am rolling around a lacrosse ball, that's a pretty high intensity of sensory input. So I'm feeling that lacrosse ball, maybe not pleasantly, but I'm not feeling the pain in the same way. And now I'm no longer using lacrosse ball, you know what? I feel better. Yeah, because I'm not using lacrosse ball anymore, okay? But I feel better. And that means I can do more because I'm feeling better. Why am I feeling better? I'm not totally sure. I just know that they do feel better. So how can I use it? Well, again, the research is showing that there is some reduction in pain. What's the mechanism? I don't really know, but it is showing that we do get reduction of pain with myofascial release. Okay, well, let's use it then. If you feel better, if your customers feel better, if your clients, if your athletes feel better, they can do more. They can continue within their exercise, continue with their conditioning, continue with their fitness routine. They feel better. I don't exactly know why they feel better, but they feel better. So while we have this window, we can get them to do more because they feel better. So perhaps it is helpful to use it as part of your warm-up routine. We already showed that it can increase range of motion acutely. It can also somewhat match other passive warm-up techniques, and it may reduce pain and therefore dysfunction. So why not use it as part of a warm-up? Especially if you're not having to do one-on-one, hands-on, self-administered. But you have to give them the time to do it. That's the other thing that happens. We're so quick to get them out there in their conditioning exercises. We're so quick to get them out there in the athletic field. We're not giving them time to prepare their bodies adequately. Claim 3, unlike static stretching, MFR does not reduce strength or performance. Well, it's great to talk about things that enhance performance. However, we always have to look to say, okay, is there any reduction of performance secondary to using this technique? The good news is great. Hasn't shown any reduction of performance. Hasn't shown any reduction of performance variables using self-administered myofascial release. So if you want them to foam roll away, foam roll away. It's not showing any reduction of performance variables of what has been researched. Not a lot of research in this area. So they looked at vertical jump, reaction time, range of motion, overall tiredness, and they saw that there was no negative effects from using myofascial release secondary to foam roller technique with it. So you don't have to worry based on this that if you have them use it as part of their warm-up, it's going to reduce their performance. So why not use it? Why not use it? I mean, so far that's where we are right now. There doesn't seem to be any downside to it, and there could potentially be a bit of an upside to it. Improves exercise recovery. We're always trying to find ways to improve exercise recovery, to be able to train our athletes harder, get them back out there quicker, be able to do enhanced repetitions of things. So we are looking for things that can improve exercise recovery. The reported way that improves exercise recovery is primarily through the fact that it can decrease pain, decrease dysfunction, decrease the sensation of tightness, and therefore help them to be able to exercise more and more intensity as well. So the empirical evidence, not a lot. We don't have a lot of exercise recovery research out there specific to myofascial release. This has shown, McDonald, Button et al. Did look at a DOM study, delayed onset muscle soreness study. So they had one group that trained with squats, repetitive squats, that gives you some DOMs, and then they had a control group. And then they had both groups use myofascial release secondary to self-administered foam rolling. And what they did find is that there was reduced negative effects of DOMs secondary to myofascial release, and then it did not hurt performance. It actually may have helped performance secondary to DOMs. So it kind of, again, we're back on, doesn't seem to hurt. Maybe it helps a little bit. Why not? So how to use it, though? Exercise prescription. Well, this is where you really come in. You should start looking at the research. What is there of it? Okay? This research did 2 by 60-second repetitions per muscle group of the thigh and gluteal muscles. So they did some hip flexors, some hamstrings, some piriformis, some quadricep, etc. And they did that 2 times for 60 seconds per group. And they did find that it did seem to be beneficial. So that's where you start. You start by saying, okay, they found this to be beneficial. It didn't seem to be negative in any way. So maybe I can start there, and then I can make changes based on how my athlete does. And so all of you that are already using it, you have your exercise prescriptions already that you're still kind of tailoring to your individual athletes. That's what we need to hear as well. One of the things you do have to realize, though, however, is how vigorous should you employ any form of massage therapy if you're trying to recover. There is research that does show sport massage, which is actually a more vigorous form of massage. So you could also take that to saying myofascial release with something that is more of a harder object or something that is done more vigorously or with a high enough intensity may actually not be a good thing. Because one of the things that can happen with too vigorous a massage, it can cause vasoconstriction. It can kind of shut down the blood flow in the area and has been shown to actually reduce the emptying of lactic acid. So you do need to be careful about the intensity of this. And one of the other things you have to be careful about is if you're thinking about habituation, or if you think about the descending pain theory, realize that sometimes your athletes are going to get to the point where they're causing harm because they're upping it every time, upping the intensity of it, upping how much repetitions they do. They're using a different apparatus to do it. And that can cause harm, which is not what we want to do. So techniques and tools. They're from very low end. I don't really recommend this, but it's in most kitchens. To higher end, okay? Actually, these are not all that costly in comparison to a really good rolling pin, so I would just go with this instead, I think, okay? But there are a lot of tools out there, and you have to find the ones that you like and work best for your athletes. What we do know is we can do parallel, we can do perpendicular, and we can do what's called compression techniques. So there's a lot of different ways that you can go about doing this depending upon whether you're not trying to increase flexibility or elongate the muscle, you're trying to break up adhesions or scar tissue, or you're trying to treat trigger points. So it's a matter of whether it's a lot of rolling or more just pressure. Manual tools. Grafting is something that would be done by a clinician and be individual one-on-one. So it's probably not something that would work for most of you if you're dealing with multiple athletes at a time. There's also a lot of other types of tools of the trade that can be utilized as well. But again, that's going to be one-on-one. Foam rollers. What's the greatness about foam rollers? Generally, they don't cost that much money. Now, you can get high-end ones that are a bit more rigid, have more fancy outer lining of them, and they're going to be more expensive. Those are the types that obviously you would want to use on larger athletes or those athletes that have already surpassed the level of kind of soft myofascial release, and you do need to be more vigorous with them. You also need to look at how are you using your foam rollers. Are you just using them for myofascial release, or are you using them for balance and core stabilization exercises? So you can get a lot of use out of a foam roller. So you definitely should have it in your setting. Then you have to look at which one do I need and what does it contain. So we have different intensities of them. So again, you need to look at the size of your athlete. You need to look at the amount of adipose tissue that they have. You need to look at the part of the body that you're trying to treat. You need to look at the amount of repetitions because they can break down after a while, and then decide what's best for your setting and your patient population. And by the way, I don't think these are comfortable at all. That's just me. Okay, then we have a lot of different foam roller exercises that can be done. I'm just going to show you just real briefly a video that you can go to. There's tons of them on YouTube. So we're back to saying, okay, which are the good ones? I like this one. I like it because nobody's talking. There is background music. I've muted it. It's not very good, all right? But it shows different ways you can use a foam roller and a tennis ball, the different body parts that it can be used on. Now, one of the things to realize about self-administered, you need to educate your patient on how to do it correctly, with correct form, correct intensity, correct repetitions. And it does require a bit of motor skill and balance to be able to do. There are some techniques that some athletes would not be able to accomplish because they don't have the range of motion or flexibility to get into the position, or it actually is putting just too much of their body weight on the foam roller or tennis ball or what have you, and that causes too much pain. So you really do have to see what are the individual needs of your clients. ITB, that's one of them it gets used for a lot. So I'm going to roll ahead here. Roll ahead. And show you here. This is on a lacrosse ball. So this is going to be a lot more vigorous, a lot more point specific. We're looking at basically your external rotators right here. Also, you're going to get some teres major and lats in there depending upon how far you roll it. So this is knowing where your restrictions lie. This is knowing where your trigger points are located. And then what is the appropriate tool to use for the purposes that you have. Yep, I got it. Let's go back to this. Okay, and again, understand that it's not just for people. See those little foam rollers there? So I guess it works in veterinary medicine too, which A&M is very big on veterinary medicine. So now, if you have any questions, I would be happy to answer anything for you. And hopefully this presentation hasn't left you looking like Captain Jack. Like, what the heck did she just talk about?